Are we good? All right. Okay, go from the beginning or are we good? From the top. Okay. Hi, this is Dr. Bob Dannenhoffer, Public Health Officer from Douglas County. This is our latest in our Facebook Live. It's Friday, July the 17th. This is one of our many. We've done now over 30 Facebook Live events. The state public health officer did the first one today, and it wasn't quite as good as ours, but it was still pretty darn good. So if you want to look at this on the OHA site, their Facebook Live. Now, interestingly, the questions they got from the rest of the state were very similar to the questions we get. And so if you want to watch that, that was good. I was watching that, and that's why we're a little late today. I got into it. Anyway, so this is a chance for you to ask questions. Put them on the chat section of Facebook Live, and we'll move from there. I have a couple of things to go over, but I'm certainly hoping that people will send in questions. So as a pandemic, this is a very active pandemic in the world. We're now at 14 million cases, 600,000 deaths. If we look throughout the world, the daily case count and the daily death count are both going up. The case count very steeply. The death count had gone down and for months had been going, each day was a little lower, but for the last 10 days is distinctly up. And the case fatality rate, that is the number of people with confirmed cases and the number of deaths, is still over 4%. And so we think this means that we're finding only a fraction of the real cases that are there. In the world, this is very active in the US, in Brazil, in India, and in South Africa. And we watch South Africa especially carefully because South Africa is a very similar country to the US in being 6 months ahead or behind of us in disease. So when we look at a flu season, they tend to be ahead of us, or we look at other seasons because now is the depth of their winter. And so we're very concerned about the big increase in South Africa and what that will mean for us 6 months from now. In the US, we're at 3.7 million cases, 141,000 deaths. So we're also, our death rate is also going up, and our daily case count and our daily death count are going up. And again, in the US, that had really been coming down for about 8 weeks. And over the last 11 days, it's starting to go up. So that is worrisome. And our case fatality rate in this country is still 3.8%, suggesting we're missing many of the cases that are out there. In Oregon, yesterday was our highest day with 429 cases. You know, you remember not back 6 or 8 weeks ago, we were 20, 40, 60, that kind of range for a long time. And now we've not been under 200 in a while, and being 429 is a lot. We're at 249 deaths. So we're adding deaths a little slower, but every day there's still some. And again, most of these older people with underlying conditions, but most of us as we get older are going to have underlying conditions. I mean, there are not very many 65-year-olds out there that don't have something. You know, between us, who among us doesn't have high blood pressure, a little obesity, some sleep apnea, or some kidney disease? I mean, these just happen as we get older. Douglas County, we're at 79 cases, up 14 cases since Monday, and up 50 cases over the last 30 days. That's a lot of cases. You remember, we went weeks at a time with no cases or maybe one case. We went 6 weeks to get between 23 and 25 cases. And now in just 5 days, we've been up 14 cases. So this is clearly more active in Douglas County than it's ever been. We have 24 people in isolation. These are people who've been diagnosed within the last 10 days and are still potentially contagious. And we have 108 in quarantine. People keep wanting to know how many recovered we had, and this is confusing because the definition changed. Using the old definition, we have about 65 that are recovered. Using the new definition, we only have 25 that are recovered, and that's why we have not posted that number, because it's really hard to explain the old and the new definition. In Douglas County, again, the overwhelming majority of our cases are stemming from out-of-state travel. And now we have cases related to travel from Alaska, Washington, Idaho, Utah, Nevada, California, Texas, Florida, and Michigan. I mean, guys, this is what we're seeing. People travel to another area, or somebody from that other area travels here. They find out that they have the disease either while they're here or right after they leave, and then they infect people who are here. Only a couple of the cases we've had here are de novo Oregon cases. Almost all of these cases come from out of area travel. And so please, please, please be careful about out-of-area travel. If you don't have to do it, don't do it. If you do have to do it when you come back, quarantine for a while before you get it into the population, because once they're here, it's really, really, really hard to get rid of. Okay, let me take some questions. So is the rapid COVID test at Mercy as accurate as those sent to the labs, Crystal asks. And the answer is no. The rapid test at Mercy is called the Abbott ID Now. It is pretty specific. We think that if you have a positive test, about 99% of the time it really is positive. And at least 50% of the time if it's negative, it really means it's negative. But it looks for a single strand of RNA, and because of that, it's just not as good as the lab test. But you trade rapidity for accuracy, and that happens with almost every test we do. April says, what current recommendations for sending high-risk kids to school or siblings of high-risk kids to school? So I'm on the governor's Healthy Schools Reopening Task Force, and we are really struggling with this. And we're struggling with this because we know that when you don't have schools, there's a lot bad that's happening, right? Kids are not getting education, and they've already missed a third of this last year, and we don't know how long this is going to last, so they get to miss another year and a half. And so when you're 60, 1 year of your life is 1/60th of your life. But if you are in second grade, 1 year of school is a seventh of your life and a third of your schooling time. And so we're really worried about kids not being in school. In addition, there are a lot of kids at school who have friends. They learn other behaviors. They may get a meal. They may get health care. So we do worry about school. And I think everybody wants to open up school. The problem with it is that when you open up school, we think there may be more cases among kids. Actually, that's not exactly clear that there will be. Other places that have done this have not seen a big uptick in the number of cases in kids because kids are otherwise around. We see kids at the playground. We see kids in the grocery store. We see kids around. It's not exactly clear that the cases will go up, but there's certainly the risk that they could go up. And there's certainly the risk that teachers could get sick. So we really worry about this. I think the guidelines on school are still very, very, very vague at this point. And there's going to have to be a lot of work over the next 6 weeks to figure out what we're going to do with schools. Because on the one hand, we want schools to open so that kids can learn and society can get a little bit back more to normal. But on the other hand, we want it to be safe for the kids and the teachers. The concern is if we send kids back to school, while there's still a lot of disease, there will be cases in school, and then those classes will have to be canceled anyway, and there'll be this hodgepodge of in and out of school. So lots more work to come, and I spent about 4 hours on this today, and I wish I could tell you know everything about it, but I don't. Okay, so Zach says, I saw a letter from another doctor in town who feels that the way we've handled COVID is all wrong. Have I seen this letter? So if you're referring to the letter from Dr. John Powell, yes, I have seen the letter. And John and I know each other for many years, and I have a great deal of respect for him, both as a doctor and as a person, as well as for all the good things that he's done for the community. There's a lot in these letters we agree about. I mean, he agrees that everybody should get a flu shot. He agrees that we really need to have excellent protection for people who are taking care of people with COVID. And he agrees that we should be extra careful to take real care for people in long-term care facilities since that's a risk. So there's a bunch we agree on. I think there's a bunch that we disagree on, and we went back and forth this weekend. I was telling people here, I think we wrote 5,000 words back and forth, looking at studies and looking at different ways. And this is exactly what should be happening in the world, is that people who really care about it should be discussing and considering other options. So there's a couple of options with disease. So we have diseases like strep throat and norovirus, and we take care of strep throat and norovirus when they come up. We don't close down restaurants because you might get norovirus. We don't close down cruise ships because you might someday get norovirus, or close down schools when there's a case of strep. We just understand that these things are going to happen, and we don't have any special preventive things. We don't do contact tracing. We don't do anything really for those diseases. We just let them go. And the reason for that is that not only would it be really hard to do, it's not that effective, because if you close down schools every time somebody had strep throat, schools would sort of never be open. So there's one strategy, which is just let this sort of blow through the population, let it sort of hit an area of equilibrium or get to a point where people develop immunity, and then you kind of get rid of it. And so that's how we as a country handle now disease like norovirus and coronavirus. And back in the 50s when I was a kid, the way we handled measles. So when I was a kid back in the 50s, as my kids say, the last millennium, Dad, and it was the last millennium, in the 50s there was no treatment for measles. There was no vaccine for measles. There was not much you could do for measles. We realized that measles was a bad disease. About maybe 1 in 1,000 or so people with measles died. And back then there were all the kinds of complications. People would get pneumonia, ear infections, be hospitalized, and other kinds of things that would happen. But since there was no treatment and no vaccine at the time, we just kind of let it blow through the society. It would go through Mrs. Smith's 3rd grade class, everybody would get it, and then it would be gone. A lot of people died, right? About 1 in 1,000 kids died of the measles. But since it was sort of the best thing we could do, that's the way we handled it. In the 60s, it became clear that we could make a vaccine, and we made a vaccine. And by that, we have totally decreased the amount of measles and tremendously decreased the death rate from measles. And so that's what we did. So you could do the same with COVID. A couple of differences there. One is that the death rate from measles was maybe 1 in 1,000. Back at a time, there were a lot of other deaths. You know, there was meningitis and all kinds of other things that people died of. And so kids dying was a much more common phenomenon than it is now. But that's the way we dealt with it. The difference is that measles, maybe 1 in 1,000 died. We think with this disease, about 6 in 1,000 will die. So this is much more serious. The second is that when you had measles, you either lived or you died. And so there weren't a lot of people with long-term complications. We know from this disease that if 6 in 1,000 will survive, there'd be a lot of other people with long-term complications. So one of the best things that happened all week is that our last hospitalized patient was discharged, but only after 100 days in the ICU and a tremendously long recovery. And so for everybody who dies, there's another couple that will have long-term issues. That wasn't really the case with measles. The other thing that happens with this is we knew that when you got measles when you were in 3rd grade, you would never again get the measles. And that was correct. I mean, there is the occasional person who's had measles twice, but it's really rare enough to be reportable. The problem with this disease is we don't know if you get it this year, could you get it again? You may or may not. I think if you asked people who really studied this, I think most of us would say for 3 to 6 months after the disease, you're likely to have immunity. But after that, it's really unclear. So the way the immunity works with measles is that you get a measles infection and your T cells say, okay, I know what measles looks like the next time this guy comes by. So the first time they have a hard time figuring it out, but once it comes by, the second time it goes, I know those guys. And your T cells then tell your B cells to make lots of antibodies. They make a ton of antibodies and they prevent the next measles infection. And that works because measles always have a level of antibodies, and we know the T cells are very smart to the measles virus, and they almost always figure it out the second time. The advantage they have is measles has a relatively long incubation period, about 8 days, so it gives a time for the T cells and the B cells to work together to make more immunity. This one, we think the T cells will work, but we aren't sure. We think the B cells will remember to make immunity, but we're not sure. And it's a relatively short incubation period, 5 or 6 days, so maybe even if you make antibodies, not enough to go ahead and prevent you from getting the infection again. So if you knew exactly that you got this disease once and never got it again, then it would be more likely to say, well, let's just let this blow through. The third thing is that there's stuff right on the horizon, right? So if you let this blow through and a lot of people die of the disease, and then next year you find that remdesivir 2 is great and prevents these deaths, then you've allowed a lot of deaths to happen. That if you were able to displace them down the way, that you might save deaths in the long run. Now, the other way to look at it is if this blows through the community and everybody gets immunity, then we'll be done with it and we'll really be done with it. The concern with that is it's never been shown for this. It's never been proven on this. No other country is kind of there yet. So that would be a guess. And the tragedy would be if you don't really get immunity, then this would continue to blow through. Or if you got a really effective treatment or a vaccine in a year from now, those deaths may be seen to be for naught. But this is a very, very, very complicated discussion. This is the first pandemic we've had in over 100 years, so we don't know the answers. And I'm not sure that anybody knows for sure the right approach. Now, the one country that has chosen kind of this approach is Sweden. So Sweden, 3 Scandinavian countries up there, Norway, Sweden, and Finland. Sweden has taken a less lockdown approach, although, people say they haven't done anything. They've done a lot of lockdown. They did almost as much lockdown as Oregon. So not as much as Italy, certainly not as much as other countries, but certainly almost as much as Oregon did. So they closed schools, they stopped big gatherings, they did some things in nursing homes. So they did some things. And what we saw comparing the 3 countries, Sweden had a lot more deaths, 10 or 20 times as many deaths as the areas around them. And when you look at the economy, their economy fared no differently than the other areas. Now, they may have enough immunity here so that the next time this sweeps through, they will have no cases, whereas Norway and Finland, they may have a lot of cases. But these are all of the unknowns, and I don't claim to be any smarter than anybody else just to know what to do. And so from a public health standpoint, what we would say is close everything down. And from a truly economic standpoint, you'd say, well, these are all old people. They don't add much to society. Just let them die. And clearly neither of those is right. We can't stay closed forever. And I think letting people die because they're mostly old and sick is ridiculously callous. So you've got to figure out somewhere in between. And I think John and I had this very long, very respectful conversation. I think he's a very smart man. He's got a lot there. But I think we've agreed to disagree about that. And that's where I think I'll tell you. I think we've agreed to disagree. So Leslie says, is the death rate going up? So when you look at deaths, you can look at the number of deaths, cumulative. Yes, they're going up because nobody comes back to life. So the number of deaths continues to go up. Cumulative deaths goes up in the country with 140,000. The second is the case count going up, so the daily death count. So if you looked at the number of daily deaths, is that going up? Yes, it is in the world, and yes, it is in the United States. The third is the death rate, and there are 2 death rates. One is the Crude fatality rate, and that is that you take the number of cases, you take the number of deaths divided by the number of known cases, and you look at that number. That's called the case fatality rate. That's currently 3.8%. That is slowly going down. So that peaked in the world at around 7% and is about 4% world and 3.8% in the US. So the case fatality rate is going down. We think the infection fatality rate has not changed, and that's the CDC reported last week about 0.65%. So it is confusing. So Leslie, if you could say specifically your question, which of these did you want? Somebody says, now that it's exploding, what does the future look like for closures? And I don't know. I think some states have already done some fairly extensive closures. So, Texas has closed restaurants, they've closed bars, they've closed down elective surgery, Florida's closed down bars, other places have done it. I don't know what we're going to do in Oregon. I think Oregon did explode about 2 or 3 weeks ago. It's pretty steady since then. So I think really we haven't lost this yet. We really have not lost control of this in Douglas County or in Oregon yet. So people would please, please, please be careful about travel. Be careful about gatherings. So many of our cases are related to out-of-state travel and to gatherings. So these are not out-of-state people who came and went to a campground or toured the area. It was people who came to Oregon and had a party of 20 and then went to another party of 20 and then went to another party of 20 and exposed all those people along the way. So be careful of gatherings like parties. Be careful about interstate travel. And I think we can get it under control. And the hope is that we don't have closures. Because in the places that have had closures, there've been these incredibly sad stories. Right? Like I had my bar and we were going. I had to lay everybody off. But, they got their enhanced unemployment, so it wasn't too bad. I was able to get a PPP loan for a couple $100,000 that helped with paying some of the staff that I needed to keep and to pay for utilities. And so we're doing okay, but the PPP is out, the enhanced unemployment is done. So at this point, if you had another closure, that is devastating to business. So I think we have to avoid that. So somebody says, why are our government hiding data? So this is a chance for all of you people who are data experts out there to tell us what to do. So on Tuesday, what we said was, if you want some kind of specific data, please, in Word format, put together exactly what kind of report you want. When you have that report, and do it in you don't have to do it in medical terms because people frequently will misuse the medical terms, but in layman's terms, like how many Oregonians died on Tuesday or that kind of thing, and then put it there, mail it to us at mail@douglaspublichealthnetwork.org, and we'll look at it and come up with the answers to those questions. So why is our government hiding data? I don't know what to make of that. So Sherry says, how many contact tracers do we have? So contact tracing is confusing because people have used it to mean many things. So the question I think should be, if we had a case here, how many people are available to go ahead and investigate that case and help people out? And the answer is that we at Douglas Public Health Network have had 5 people all along who could investigate cases of all kinds of things: food poisoning, COVID, bed bugs, the whole deal. And so we have 5 contact tracers that we've already hired. So they can do contact tracing, but obviously we do other things too. And then we've hired another 15 people whose job it is to help us doing that. Some will be case investigators. Some are people we call support specialists who deliver meals to people. I'm going to be one of those tomorrow. So I'm going out to Reedsport tomorrow to deliver, I have to remember to do that, and to deliver thermometers and pulse oximeters to some contacts out in the Reedsport area. We're going to do some shopping for some stuff that people need. So altogether, we have on our staff about 17 or 18 people who can do that. In addition, there are a bunch of community-based organizations that got money to help with that. The tribe has some people who are helping with that, and I just got an email today that there's other tribes that are willing to help with that. And then there are other community-based organizations that have been incredible help. So for example, we had a group of people who needed some food, and the food bank was able to put together the food that they needed to go ahead and do that. And that would be, in the broadest sense, contact tracing. So when I put it all together and got the number is something like 40 people who could help out when we needed it. We don't need that many now. We have 108 or so contacts that we're following now. Some people need nothing. They're at home and they're just at home. Some people need a lot because, for example, they're in a hotel and need us to deliver food 3 times a day. And some people need something in between. We've been able to meet all of those needs in a very efficient way. So just the number is a little hard because people mean different things. So like, yes, I'm going to do this tomorrow, but would you call me a contact tracer? I don't know. I think you'd call me the public health officer. But yes, I'm going to be working on that business. So Debbie said, if you were to wear a mask and able to socially distance, should you be safe? Yeah, pretty safe. Now, 100%, nobody's 100% safe, but really pretty safe. We don't think we've identified a single case where they wore a mask and saw 6 feet away and still got sick. Almost all of these, a family gathering, and everybody was in the room and hugging and sharing a meal and sharing a buffet and whatever. That's where people got the disease. We've not had anybody who's been able to do the social distancing in the mask who has been positive. So you can never say 100%, but pretty close. So tell me about RomTech. Does this mean there's big community spread now? We don't think so. We heard about these cases early. The people at RomTech were great to work with, and we narrowed these all down. They're almost all done with quarantine at this point. So we think that, yeah, there was a little outbreak there, but we don't think it's spread any further. And that's exactly what's supposed to happen. So, with public health, we found all these contacts, we quarantined people and sent them home, and we think now that there are not other new cases. We'll see in the next week or two if there are, but we don't think they're going to be. They're out to a point where if there are going to be more cases, we would see that. And so we don't think there was a lot of community spread. Now, in all these cases, we look at who the contacts are. So the contacts are, on the night before my poker, I had a poker game with people. We tell all those people in the poker game that their contacts, ask them to quarantine. If later one of them gets sick, they're already quarantined and hopefully don't make anybody sick down the line. So when we go past that, we don't think we've seen any second generation cases. However, as more and more people get sick, there are going to be asymptomatic people where we don't know where the stuff comes from. And that's where we're pleading with people to be careful about travel and to be careful about parties and social distancing. So what percent of our cases are children? 0. So our youngest case is 16. And do they present differently? Yes, in the rest of the world, since we have any cases, I can't tell you about ours, but in the rest of the world, kids tend to be very, very mildly ill or asymptomatic. They're typically picked up because they're part of an outbreak. Parents have the disease and you check the kids, and that's where they're positive, but they don't. Now the question is, are we screening enough kids to know? We're not screening that many kids, but all the kids we've screened so far have been negative. So John says, how does testing differ between COVID-19 and other coronaviruses that make up common colds? Well, so you can test for the coronaviruses that cause common colds, but we almost never do so. Occasionally, if you have somebody who's really sick, they'll do a thing called a respiratory panel PCR that looks for the viral DNA or RNA from multiple different organisms. And so occasionally we'll find a coronavirus in that, but generally we don't test for that. The difference in testing with COVID-19 is that it's testing just for COVID-19, and COVID-19 is probably 1,000 or 10,000 times more deadly than the other coronaviruses, and that's why we don't test for the other coronaviruses. So thoughts on using the bike path, Gabrielle says. Well, bike path is pretty safe. If you saw the video on doing the bubbles, you'd be hard pressed to get more than 1 or 2 bubbles on the bike path. So I love to bike. I bike all the time, and when I do, I wear my balaclava, and when there's nobody else around, I put it down, and when somebody else comes by, I put it up, drive through. If you did that, I think you could be perfectly safe. So why change the recovery rate? Seems like recovered is recovered. Yeah, I know. So Dr. Seidlinger discussed this today. The issue was that recovered for most diseases is recovered. So with measles, a week after you get done with the measles, you're no longer contagious and you're recovered. So in general, the default position is recovered and released from isolation are the same time, because for most diseases, that's correct. However, what we found for COVID is it's not like most other diseases. So it's really not like most other diseases. People are sick, can be sick for a very long time, like our guy who just got out of the hospital. And then other people are asymptomatic. So to call people recovered while they have no symptoms, to call them not recovered while they still have symptoms made little sense. And so the state and territorial epidemiologists, a group of people, smart people, decided that one of the ways to do this was to make it a time, 60 days after the disease. And there are a bunch of other diseases that we do that for. So this is not similar to COVID. And yes, it is really, really confusing when you change the definition along the way. But recovered is not really recovered because initially the definition of recovered was a little wonky. And the definition of now of recovered is a little wonky, right? So that if I was symptomatic, had a little cold and cough, after 10 days, my cough and fever are gone, I'm feeling great, to not be considered recovered for 60 days doesn't seem right either. So if you have a better way to call it, then you tell us, and it's called mail@douglaspublichealthnetwork.org, and we'll consider that. So what do you think about Lane County testing 300 asymptomatic people? I thought we were low on testing supplies. They're using a different testing strategy on that. And this is a sort of a research thing that they're doing in Lane County to see what the background rate of disease is. And they use a different lab platform and a different lab testing. Now, at some point, we may stop doing these screening things because they are using up some supplies. So the supplies that they're especially using up are primers and reagents. They have, I think, right now, primers and reagents are not the limiting factor. The limiting factor on testing now are swabs, and they're using a different swab. So they're not using the deep nasal swab, so they're not using those up. And just the machines that can do rapid stuff. And since this is on a different platform, this is what Lane County is doing is not, at this point, really impacting what goes on. However, who knows what's going to happen in the next week on that. So face-based facial shields, which is best? Whichever you prefer. We think both are really quite effective. I like a face shield for some things, and I like a balaclava for other things. So whichever you prefer. The advantage of face shields is that people can see your lips and can read lips. And I'm always struck by the number of people who read lips, and I think I probably do it a little bit too, because I find it a little harder to understand people when they wear a mask. I really hate the mask just for the heat and whatever else. So whichever you like is better. So are some businesses exempt from enforcing masks? So no businesses are exempt from enforcing masks. But again, there's no mask police out there. And people can decline to wear masks and say it's for a medical reason, and we're not going to go ahead and be doing a medical exam to see if you can or cannot wear a mask. Again, there are maybe a few people out there who can't wear a mask because they've got severe COPD or something else. But if you are that severe in your COPD, you probably shouldn't be out anyway. And there's some people who've had traumatic experiences. There's a person that I know who said that they had been sexually abused, and during that time they had their mouth covered. And so any covering their mouth is deeply troubling to them, and they can't wear a mask for any reason. And, so they wanted to be in medicine. They couldn't go into medicine because the idea of having to wear a mask in the OR was just so abhorrent, so they went ahead and did something else. And so I get that. And so if you're one of the people that had that terrible experience, if you have horrible COPD, please don't. You might consider a face shield because those don't affect COPD, and it may be different. But again, that's just a small percent of the population. If everybody else was wearing a mask, we wouldn't have to worry about that small amount. What I do worry about is people who are not wearing masks and shouting, because the people who are not wearing masks and shouting, they're the ones that are most likely to go ahead and give this to others. So what concerns do you have with reporting hospitalizations from moving from the CDC to the White House? What effect will it have in Oregon? This looks like just boys and their toys, as my wife calls it, when men do stupid things. This looks like boys and their toys and fighting about who gets the data. It's going to make no difference to us. I mean, we get hospitalization data directly from the hospital. We don't either get it from the CDC or HHS. And so I don't think it's going to make a big difference here in Oregon, or certainly not for us. But I think what it shows, though, is the fact that we're still not all on the same page here. Guys, we've got to get on the same page here about this. And so this little tiff over the last 3 days is a total distraction from the important things, which is, do we have enough PPE for the people in nursing homes? Can we get tests back in a time? Those are really, for me right now, the critical issues. And deciding as a country, what do we want to do about schools? Is it safe to go to schools if, and I'll pose this question to people, if, in the school, we have about 12,000 kids in school. So maybe plus or minus a little bit, but about 12,000 kids in school. We have, we have that maybe 500 to 1,000 teachers, school aides, and other people there. So let's say we have 800 teachers and aides. We have 12,000 kids. Okay, so let me get this right. So 800 teachers, 12,000 kids. In our county, how many kid cases, how many kid hospitalizations, how many teacher cases, how many teacher hospitalizations and teacher deaths would we say is totally unreasonable for us to open school? Some people may say 1. Some people say, well, teachers die of all kinds of things. Kids could get into bike wrecks or car wrecks or whatever. And so a number of 0 is not reasonable. But I don't think anybody would think that the number of 40 teachers dying would be acceptable to anybody. So you have to set that continuum. And those are the kind of discussions we should be having as a society, because people's risk tolerance differs. And so I was working with a school today, and they said, well, Bob, tell me what you would do. So we had a school situation where the risk to the teachers was 1 in 1,000. I said, if the risk of me dying as a teacher was 1 in 1,000, I would do it, because my risk of dying in a car wreck or whatever is about 1 in 1,000. And I realized that schools must go on, so if my risk was 1 in 1,000, I think that would be fine. And then we did a different scenario where my risk of dying was about 1.5%. So 15 times 15 times what we were talking about before. At 1.5%, I would be really cautious. I mean, 1.5% is far more than my risk of dying in a year, about 0.1% from accidents, and is even 3 times as high as living my year of living dangerously. So people have been watching here said, my risk of dying in an accident this next year is about 1 in 1,000. Because I'm relatively safe, I drive a safe car, I never speed, I never drive drunk, I wear a helmet when I ride my bike, I don't do any high-risk activities. So when I looked at it, it's about 1 in 1,000. But if I were to take the most risky year, trade away my car for a motorcycle, every weekend go scuba diving or skydiving, or fly a commercial private plane. So doing all those risky things, flying a private plane, scuba diving, skydiving, riding a motorcycle, my risk would be 0.5% per year. For me, that's far more risk than I would normally take. But my risk of dying in COVID in a year, assuming that 60% of the people get it, and my risk of dying is about 0.2 or 0.3, that may be a 1.5% risk of dying in the year. That's high. And so we have to look at this as a society and decide what is the reasonable risk levels for going back to school. And I'll bet some people say if a single teacher was hospitalized, that would be too many. And some people would say, well, we could accept a higher rate. And these are the kind of discussions we should be having. This craziness with the CDC and HHS figuring out who gets the papers first, to me, is just crazy. So Midge says, does a portable oxygen concentrator remove the virus? You'll have to look and see. Some of these have HEPA filters, which would. Some of these do not, in which case they wouldn't. So you have to see if they have a HEPA filter. So Nita says, are false positives or false negatives common? No. So let me tell you about false positives. So false positives would be time you do a test and says, oh, you've got COVID, when you really don't. We think the worst test out there for that is probably at least 95% accurate, that if you have symptoms, you likely have, if you have a positive, you likely have it. We think the best of the tests are like 99.9, which is really, really good. And so false positives would not really be a problem if you were sick. Because if I was sick and went in and they said, Bob, there's a 97.3% chance that you have COVID, but there's a 2.7% chance that this is a false positive, I'd say, well, I probably have COVID then. The problem is if you start screening lots of asymptomatic people. So let's say you would screen 100,000 asymptomatic people and the test was 97.3. That would mean that 2.7 out of that 100,000 people, or 2,700 people, would get back a false positive result when they didn't have any disease at all. And that's why you really, really want to be careful about asymptomatic testing, and why I'm not a big fan of asymptomatic testing, because we will unfortunately tell 1 or 2 or 3% of people who take the test and are perfectly well, and really are perfectly well, that they have the disease and cause them endless worry. And that's why I'm not a big fan of asymptomatic testing. False negatives are a little bit more common. So false negative says you have the disease, we do the test, and can we find the RNA? And the answer is there are some false positives, maybe up to 30%. And the reason for that is you may not have a lot of virus in the beginning of the disease. So you have the disease, but you don't yet have a lot of virus. The second is it's really hard to find virus sometimes. When I'm doing these swabs, I'm going in 5 inches blind, and I may not actually hit any mucus along the way. I usually do, but I may not hit any mucus along the way, and so I pull it out. You've had the test. I've done it the very best way it could be done, and yet there's no virus in there because I just didn't happen to hit any mucus. The other possibility is that some of these require refrigeration along the way, and the refrigeration could go wrong, and the test may not find a low level of virus. So yes, there probably are a few percent false positives, and that's why I'm cautious about screening big populations. And there may be 20 or 30% false negatives, and that's why I'm really, really cautious. I had a negative test, so I can go back to work. Or I had one just this afternoon where somebody was clearly a contact. And they said, well, if you did a negative test, then I could go back to work. And the answer is no, you're a contact. Having a negative test today is not enough reassurance for you to go back to work and expose other people. So yes, you can get false positive and you can get false negatives. So a few other things that we found in the literature this week. So again, the CDC said that 20 to 40% of people will be asymptomatic. Their best guess at this point is 40%. That the R naught, that is how many people will get infected from a person who has it. The original range was 1.7 to 3.4. Their best estimate at this point is 2.5. That means that everybody who gets it would infect another 2.5 people, which means that this disease, if left unchecked, could grow rapidly. And then the infection fatality rate, that is for every 100 people who have the disease, what percentage will die? They have 0.65%. So between 1/2 and 1 person out of 100 would die. Again, I've been predicting all along that's going to be somewhere between 0.4 and 2%. So 0.65 is right in that mid-range. One of the stories is, well, can everybody get this disease? Maybe are people already immune? And there could be some people. So there was a study today from England suggested that some people may be already immune to it because they've had one of the other coronaviruses, and that could be true. Although when we look at the Skagit Chorale, which is these choir that sang up in Skagit, and 50 of 62 people got infected, suggested there must not be very many people out there who have natural immunity. There was this cruise that went down to Antarctica. 60% of the people on the cruise got it, despite the fact that when the first person had fever, everybody was quarantined to the room. So they did a lot of work to quarantine everybody else, but still 60% of the people got it. So if there are a lot of people immune, I haven't seen that in the other data. Two other things that came out. One is that when you look at heart scans of people who had COVID, many of them look like they have long-standing changes on their hearts. That is not great news, because these changes that they've seen in their heart, these interval changes that they've seen, do appear to be long-lasting, and that's a worry. These are even people who are not that sick. And then they also looked at people who had mild or asymptomatic disease. These were not people sick enough to be in the hospital. And they said, hey, let's do CT scans to see if there's any changes. Almost all of them had abnormal chest CTs. So even people with mild disease or asymptomatic had some abnormal CTs. And then the third one that came out was an autopsy study that looked at people who died, and the pathologists were just shocked at how much clotting they had all throughout the body. So it does seem that clotting is a big deal. So if you flew across country in 2 flights, how long should you quarantine after getting home? 2 weeks, 14 days. So get home, go to a room, have somebody deliver meals to your door, use the bathroom all by yourself. Don't share bathrooms if you can. Stay in your room, catch up on your reading, catch up on your Netflix, stay in your room for 2 weeks, then you're good to go. Testing, you could or could not test. I'm not a big fan of testing if you're asymptomatic. Clearly, if you get symptomatic, you should get tested. But if you're asymptomatic, stay in your room for 2 weeks. You'll be no risk to anyone. Yeah, are there more cases in the world of pets and cats testing positive? Yes, there are. So as you get more cases, not surprisingly, that people have contact with their cats and dogs, and they'll be positive. But it seems that cats and dogs are kind of dead-end hosts. So although they get the disease and they get kind of sick with it, they tend not to get really sick with it, and they tend not to infect lots of others. Now, You know, there have been a lot of cases actually in the Bronx Zoo and the Central Park Zoo have been two of the most interesting places because they did a lot of testing in those areas and they were in big endemic areas. And actually a lot of the cats did test positive, but we don't think there were any deaths among the large cats, and we don't think there was any spread from cats back to people. So again, it looks like the cats are probably dead-end hosts. One of the other things that came up, we got some more questions about this budesonide. So there's this doctor from Texas who is saying that he's using budesonide, also known as Pulmicort, in people who have mild disease, and he's seeing magical results, 100% recovery and no worsening, and really this recovery within just a few hours of getting the thing. His reports are really very, very striking because indeed this was true, this was great. But I have looked again and again to see if there's any other backing for this, right? This has been out for 3 weeks now, so presumably a lot of other people would try it, and they would try and say, hey, it worked well for me too, and I've not seen any of the secondary things that have helped. And he's in a part of Texas that has had just as much disease and just as many deaths as others. So if people in his group are using it, it hasn't seemed to affect it. But boy, wouldn't it be great? Wouldn't it be great to have something like inhaled budesonide? And I am very hopeful that we're going to have a vaccine or a treatment or something out of the blue that comes up that's going to make the death rate for this much lower. In which case, keeping the case count as low as we can for as long as we can allows us to use one of those things. Going back to my earlier story on the measles, and it was a long story, but going to the story on the measles, you know, keeping measles out of the population didn't make sense because there was no measles vaccine on the horizon. And when it came out in the mid-60s, there was, basically what happened is we just immunized everybody, and the measles rate went way, 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 way down. So this one, I think we're making progress on a vaccine. Dr. Redfield spoke today, thought that there was good progress on a vaccine, and that's good to know. And so, you know, the hope is we can keep this down to a dull roar until we either get effective treatment or a vaccine or something else, and then we can look at this in the rearview mirror. We'll try and post something. A friend of mine from my fraternity. So when I was in college, I was in a fraternity. It was hard to believe that any of us came out of that alive or with any brain cells, given the way we were a little imprudent during that time. But anyway, so this guy's now a Harvard virologist. He's really well known and famous. And so I reached out to him recently, and he gave a very good talk about what this is going to look like from giving a talk to the class of 2045 about what COVID was and what it did. And so it's a very interesting and a really heartening thing that yes, we're going to get through this. We're not going to get through this without some pain and without some deaths. So I have another challenge for people, because every day I get emails and tweets and everybody else. The governor shouldn't be doing this, and she should do this, and she shouldn't do this. So we're going to have a new challenge here, which is called "You Are the Governor Today." And so the challenge is, if you were the governor today, what would you do? And please don't put a lot of likes, nuts. Like, I wouldn't require masks, and I wouldn't do this, I wouldn't do that. Tell us what you would do. And so your answer might be, I would do nothing. I would just let this play out. Yours may be, I would lock everything down again. Mine would be, I would close the borders. And so you are governor for the day. And so I would like people to give their comprehensive plan as governor for what you would do. And again, send it to mail@douglaspublichealthnetwork.org. Now, we didn't get any responses, I don't think, for the reporting. So so if you still have ideas on how you want the report, please send that to mail@douglaspublichealthnetwork.org. Or if you want to be governor for a day and tell us what you would do as governor, please again send that to mail@douglaspublichealthnetwork.org. And we'll look at it. And we may even present it here, because people may come up with some great ideas about what the governor should or shouldn't do. Now, I actually talk to the governor on a regular basis, so if it's a really good idea, I'll even share it with her. All right, any more questions? Okay, we're done with questions. 6:52, and time to go. So again, this is Dr. Bob Dannenhoffer from the Public Health Officer in Douglas County. Thank you again for all the great questions today, and we'll do this again on Tuesday. Thanks.